Okay. Duncan Neilson, as she pointed out, I'm an OBGYN physician. My training actually was in OBGYN and GYN oncology. My training predated the oncology board, so I wound up practicing general OBGYN and GYN oncology in Portland, starting actually in 1974. So I practiced for a long time in that community and became, over the years, pretty much involved with the hospital and to some extent the hospital system. By that I mean I was department chair for the OB/GYN department. I was medical staff president. I was on several board quality positions. I was ultimately on the system board, ultimately even vice president of the system board. So I kind of made a lot of contacts and so forth. And then just about 9 years ago, I accepted a position leaving my practice and becoming the system-wide medical director for women's and initially just women's services, but it wound up being women's surgical services, so kind of an interesting switch in my world. Thought it was going to be a little bit less demanding with less night call. Turned out it was more of a fry pan to the fire type of move. But at any rate, my relationship during really 30 years of practice, my relationship to the home birthing community was much like that of ships passing in the night. You know, I was always too busy and sleep deprived to notice much of what was going on, except that I was aware of some hostility between my fellow physicians and our hospital staffs and the home birth nursing community, and there were also some sort of publicly, exaggerated, you might say, conflicts between these, but that was really about as much as I knew about it. Then when I took on this position, I suddenly found myself as the owner of that particular conflict, which was a curious position to be in. And I realized that one of our missions is to be of service to the community. And in our community in Portland, you saw that Oregon has a high rate of out-of-hospital birth. Actually, the Portland area is considerably higher than the numbers that you saw there. And probably something at least on the order of 5% of the births in our immediate area are planned out-of-hospital births. And so I thought, well, if I'm supposed to live up to my commitment, I really have to somehow address this, because this is the community that we live in. It's not whether I oppose or promote out-of-hospital birth. It's that I realize that this is my job now. This is what I do. And so I kind of had to address this hostility. I was helped in this by a couple of phone calls, one from a very eloquent certified nurse midwife at OHSU, the Oregon Health and Sciences University, who had tried to transfer a patient to one of our hospitals during labor and received so much flack and criticism and expletives over the phone, in other words, so much overt hostility, that she wound up not pursuing that transfer, which would have been a very important transfer. And that occurred to me that was actually a real system failure. Here was a patient that needed the help. The patient was actually a physician, and her husband was a physician. I mean, when I learned more about this story and realized what was going on and how massive this failure was, it was really quite embarrassing. And then the second thing that happened was that I had a call from one of the community midwife, one of the community providers, who had transferred a newborn into our neonatal intensive care unit after a sort of surprise outcome where it appeared that this newborn had some degree of encephalopathy. And the midwifery group, there are actually several of them, had no idea why this had happened, but she knew that we did case reviews and wondered if she could come to the case review. And I thought, wow, that sounds good. And so, of course, without consulting risk management, legal, and I just said, sure, come on over. And so when they presented the case review, 3 midwives from that group appeared, and they had wonderful records. They described the patient's history, they described the management of the labor, and everything, and then wondered what our impressions were. And we started a very, very productive conversation. Another one of my tasks, we have 2 tertiary care hospitals, and our largest hospital is a very high-end tertiary hospital. By that I mean we have a level 1 trauma program, we have the regional burn center, we are the regional ECMO center, we have the second children's hospital in the Portland area, which again does high-level, level 3 neonatal intensive care. We have all the pediatric subspecialties, so we really have a tertiary care hospital. I needed to find a way to support our maternal fetal medicine program and came up with the idea of starting an OB hospitalist program to serve as maternal fetal medicine extenders. Then we could extend our maternal fetal medicine program to our second largest hospital. That was sort of my challenge. So I wound up developing an OB hospitalist program, and then having these conversations with the home birth midwives and having an employed certified nurse midwife program at our largest hospital that I was now in charge of. So the picture here is that I'm now in charge of the maternal fetal medicine program and in charge of the employed nurse midwife program in the hospital. It occurred to me that I actually had a substrate wherein I could start to address the hostilities with the community midwives. Now, prior to instituting the hospitalist program at the large hospital, I had done one at the smaller hospital first. The large hospital is a teaching hospital, so the situation was that we had a group of in-house faculty whose presence was required by our need to meet the resident accreditation requirements. So to have residents, you have to have in-house faculty 24/7. So we created a call rotation where community physicians who were on the medical staff would agree to stay in-house nights and weekends and cover the resident service. It turned out that these were the people who also were generally on emergency room calls, so they were the ones that were fielding the calls, the occasional calls that would come in from the community to transfer patients. And they actually were the source of much of the hostility between the community and the hospital. And so after some conversations with them about this, it occurred to me that if I could get a hospitalist program in, I would replace this whole hodgepodge of affiliated physicians who just were really governed by their fear of this world, and replace them with 4 people over whom I had a fair amount of, I had command and control. But more interestingly, I really had the ability to carry on constructive dialogue about how we wanted to optimize our services. At that time, our nurse midwives, by medical staff bylaws, were not allowed to accept intrapartum transfers. Such transfers had to go to a board-certified OBGYN. That was simply the hospital rule. So it seemed like if we were going to improve the relationships with the community, the first thing we had to do was change the hospital bylaws, because I thought it would be much more acceptable to both the community midwives and to their clients if they could transfer to another midwife that had hospital privileges rather than transfer to an OB who most of them didn't know, didn't trust, and probably feared. And so I thought, the problem, or one of the big problems of trying to reach out to the community to improve the relationships and hopefully improve the care was that while we could deal with policies, what we were really going to be dealing with was a major culture clash. And how to navigate the culture clash and soften that was what I felt was the biggest challenge. And step 1, I thought, was to make the primary recipient of transfers be another midwife. And the neat thing then is that the system we had was that the required MD backup for the midwifery service was now, by my command and control, the 4 OB hospitals. So they agreed that if the midwife would accept community transfers, they would provide the OB backup for them. And this is what really turned the corner for us. And we had, prior to that time, very few transfers to any of our hospitals. We would have just a couple a year. And the typical scenario would be that something had gone dreadfully wrong, and the community midwives, after exploring their options, would finally, and receiving nothing but hostile response from the various hospitals, would have the patient transported to the hospital by ambulance, and then they would all bolt and just leave the patient in the emergency room to the care of whoever was on emergency call. And we called these train wrecks because they, when there were problems going, but when they hit us, the problems only compounded until you actually got things under control. Hold it close, thank you, I'm sorry. So then, but after we created the system of midwife transfer, suddenly the community midwives felt more free to talk to our midwives and prepare these patients for transfer. The hospitals were very supportive to this, and a lot of the barriers began to crumble pretty quickly. And first we would have a couple of transfers a month, and then we would go back to the community midwives and discuss how we succeeded or more likely initially failed, because we didn't meet everybody's expectations. Right at first there was a steep learning curve for everyone. But, and we would go to the communities. My lead midwife and I, and sometimes one of the hospitals, would go to the practice sites of particular community midwives, and we would say, what did we do well, what did we do poorly, how are we going to do it better the next time, and so forth. And we just basically created these relationships to the point that we wound up seeing on more an average of 2 transfers per week into our program. And we began getting very positive feedback from the clients/patients who were transferred, who said, they had no idea hospital care could be friendly and so forth. And our outcomes, and I'll just finish with a couple of numbers here. Our outcomes, we now, I just got an email of the 2013 transfers. We transferred into our midwifery database 86 patients, which isn't the whole story because the direct transfers to the hospitalists, we don't have a good way to count because there's no code for that. But at any rate, it's roughly 100 per year that we get. Our C-section rate out of those 86 was 41 C-sections. The rest all delivered vaginally. The outcomes, there wasn't a single bad outcome in the group that wasn't already predetermined by something that no one had control over. So it has been now and we have expanded the same work to all of the other 5